Rochelle, you can stop sharing. Later you can share.
Good evening, everyone. Welcome back. Now, we are once again back with another episode of Allergy Forum. Today is episode 9, and in which we will be discussing about another topic on eosinophilic puzzle. If you remember, in the last Allergy Forum case based discussion, we discussed about eosinophilic esophagitis. So, this will be in succession to that another interesting case in which another problem in which a patient is having eosinophilic predominance at various places, and then how this patient was approached and managed. So, this will be discussed. So, I would like to invite moderator of the day, Dr. Sanchana Bhatt. Dr. Sanchana, you know very well. So, she is the National Coordinator for Allergy Forum, and she is the pediatric allergist from Bangalore. So, Dr. Sanchana, please take over.
Thank you, Neeraj sir. A very good evening to one and all. And it is with great pleasure that I would like to invite for today's session Dr. Kalapanavar sir. Sir is a moderator for today's session, and he is a former medical director and currently is a professor and HOD of pediatrics and consultant pediatric pulmonologist at SS Institute of Medical Sciences and Research Center, Davangere. Sir has also got elected as the EB member of Central IAP with a thumping number of votes this year for the 2026, and he was also the president of IAP NRC in the year 2024, and I was very fortunate to have been associated with him as an EB member that time. And sir is successfully running the fellowship course of pediatric pulmonology in his institute, and sir has trained many postgraduates and fellows, and he's an excellent teacher and a great academician. In fact, I still remember the first ATM which sir attended, and he's always been a guide and mentor to me after that. And my interest in allergy definitely was began after that. And welcome you, sir. We are extremely fortunate that, in spite of your busy schedule, you could make some time for to share your thoughts on this case discussion and moderate this session. We are fortunate to have you here. And now I would like to welcome Dr. Rochelle Natasha Gomes, who is going to present the case for today. Dr. Rochelle actually completed her MD from Manipal, KMC Manipal, and later on she started pursuing a fellowship in pediatric pulmonology at SS Institute of Medical Sciences and Research Center. I think this field holds a special importance, and she's also, in fact, interested in allergy, and she's very much interested in research, and personally I know her very well, and this I think this episode is very special because both the moderator and the presenter are very close to me, and I kind of I'm really I look upon them, and we would love to have an excellent case discussion and looking forward for that. Welcome, Dr. Rochelle. I think you can begin to share the screen actually.
Thank you, ma'am. Ma'am, are my slides visible?
Yes, it's perfect.
Good evening, everyone. I'm Dr. Rochelle. I'm pursuing my fellowship in pediatric pulmonology at SSIMS and RC Davangere under the mentorship of Kalapnavar sir. And this evening, I will be discussing my case presentation entitled Unraveling the Eosinophil Puzzle. So, demographic details presenting the case of a 1.5-year-old male toddler named Master A from Rani Bennur. The informant is the mother, and he was admitted with us on the 2nd of November this year. With the chief complaints of cough for a week, runny nose since a week, and fever since 5 days. History of presenting illness. The toddler has had cough for a week, which was insidious in onset and progressive, wet in nature, aggravated on lying down, more in the early mornings. not associated with post-acid vomiting or with exertion or laughing or crying or coughing up of blood. He has also had running nose, watery nasal discharge for a week. He has had fever for 5 days, which is insidious in onset, intermittent type, not associated with chills, and relieved temporarily on medication with no diurnal variation. Mother also gives complaints of decreased activity and oral intake for the past 2 days. There has been no history of ear discharge or pain or mouth breathing or snoring, no history of hurried or noisy breathing, no history of bluish discoloration of lips or peripheries or swelling of feet. There is no history of recurrent vomiting or cough in relation to feeds or regurgitation of feeds or difficulty in sucking or swallowing feeds. No history of choking episodes or excessive crying while feeding. I have taken this negative history because there is a significant past history of recurrent such similar episodes. There is no history of rash or skin lesions or infections elsewhere in the body. No history of failure to gain weight or loss of weight. According to the parents, the growth is normal.
Okay. Uh, can I just stop you here for a while, Dr. Rochelle? Just if you go through the chief complaints, what has struck to you in a toddler or 1.5-year-old child? Cough, running nose, and fever for 5 days.
So it could be a viral fever with
Mhm.
other been
Yeah,
complicated maybe with a bacterial infection
yeah.
because it's
So,
there since a week.
yeah. See, what happens is this is very important. In this age, you should think those things first. Okay. You are not gone to the past history. Significant history is cough, running nose. So
Yes,
running nose, that probably tells you that it is a viral coryza.
yes,
Okay.
sir.
So coryza following cough, fever, what do you expect to have, child? What next question you will ask? If you see the history of presenting illness, which is there in your history, what you would like to ask?
The type of cough, sir,
Very
aggravating
good.
factors,
Yes.
variation, sir.
Yeah, very important is nature of the cough is very important. Okay. So next, the important question is whether it is associated with any hurried breathing.
Yes, sir.
Hurried breathing makes all the difference. So what conditions keeping in mind, you will ask these two questions? Nature
So
of the cough and hurried breathing in a child who has got viral coryza. Like, he had history of cough, running nose and fever.
yes, sir. So first, because of the age group, we have to keep in mind about bronchiolitis
Very good. Next.
and episodic viral wheezes.
No, another important is you should keep in mind croup.
True. Yes, sir.
Yeah, that is the reason you are asking about nature of the cough.
Yes, sir.
So if it is a barking cough or metallic cough, so in addition, the child has got hurried breathing. Next question, what you would like to ask is?
The sound of cough.
Yes, not sound of the cough. That is the nature of.
Nature. Nature of cough.
No, is it associated with any noisy breathing?
Yes, sir.
So these two important questions one has to keep in mind. If you get a history of this, any child who has come with an acute history of fever, running nose, cough, these two important things you should always keep in mind. So one, it will tell you that it is a viral origin in nature. Second thing is subsequently what can happen to these children is any child less than 2 years, so suddenly developed following this coryza and running nose, it is likely to be a bronchiolitis. If
Yes,
the
sir.
same child has developed a noisy breathing with a barking cough, likely to be developing croup. So these two are very important in this child. So that is the reason this history makes a lot of difference. So anyway, you have asked those two questions. There was no history of hurried breathing. Understand?
Yes, sir.
So that second important history, what is most important history here is wet cough.
Yes, sir.
So that is something which will tell you that it is usually a lower respiratory infection is involved. Okay. So always we should emphasize on that because running nose is not a nature of bacterial infection. Okay. So you should always keep in mind and ask about this. So these three are very important. Nature of cough, quality of the cough, and third thing is noisy breathing and hurried breathing. So if you are aware about this, because these two are very common entities. Okay, very common entities. One has to keep in, especially children of less than 2 years of age. Okay, you can proceed.
Yes, sir. Coming to the past history, he was diagnosed with atopic dermatitis, which was documented at 2 months of age, and for the same, he was prescribed emollients. At 6 months of age, he had an episode of pneumonia wherein he presented with wet cough, running nose, and fever since 3 days, with hurried breathing for 1 day. And he required a 7-day hospital stay requiring oxygen support, nebulization, and IV antibiotic for 5 days. Following this, he was completely normal and his episode completely resolved. After 2 months, again he had a similar episode as in the 6 months of age. Again, he required nebulization, IV antibiotics, and a hospital stay for 5 days.
Okay, next. Okay.
So then following this, he has had history of frequent nebulizations with a good response after the nebulization every 2 weeks to a 1 month period. And then at 1 year, 5 months, 1 month prior to getting admitted with us, he has presented with cough, fever, hurried breathing, and wheeze. Acute severe asthma was documented and he has required nebulization and hospital stay for 3 days, wherein he was started on MDI formoterol plus Budecort with a spacer and mask, and he has been continuing the same treatment for a month.
Okay. So now you take up these two parts. One is the chief complaints and the significant history of present illness and past history. So what strike to your mind? What is significant history in the past?
There is a history of 2 documented pneumonia episodes, sir, which has been
Okay.
requiring IV antibiotics. And
Okay.
furthermore, there has been a history of recurrent nebulization use also with a good response.
So
And also,
what do you think? What do you think? Does pneumonia require nebulization?
no, sir, pneumonia doesn't require. So
Okay.
maybe that period, maybe he would have had a bronchiolitis. And
Mhm. Yes. Okay. Bronchiolitis doesn't happen recurrent, isn't it? What do you think?
maybe these were also episodes of wheeze, sir.
Yes.
Recurrent episodes of
So
wheeze.
very good. So the possibility, what happens in a clinical setting, many of them, looking at the history and the examinations, they label them as pneumonia. Okay? They label them as pneumonia. So we have to keep in mind, unless they have a radiological evidences wherein we should think. If there is imagine there is a radiological evidence in this patient documented and he came with a similar past history, what you can think?
Recurrent wheezing episodes probably points to a diagnosis of asthma, sir, because it is also responded to nebulizations. Two
Yeah,
or more
very good.
episodes.
No, another important history, if there is a documented, as I said, pneumonia, which is requiring antibiotic, recurrent pneumonia.
Pneumonia. Yes, sir.
Okay, that is very important, no?
Yes,
So
sir.
this child, either it had got a recurrent pneumonia, so that we should see, or we don't know whether it has got a radiological evidence for saying it is a persistent pneumonia. Okay, so these two things we should keep in mind in such a significant history. The third thing here is this child has got very important history. You have atopic march.
Dermatitis. Yes, sir.
Yes. So a documented, diagnosed, the physician labeled atopic dermatitis. Okay. Thereafter, every episode of hospitalization as well as every episode was treated with a nebulization, isn't it? And fortunately, in the last episode a month ago, this child was seen by a physician and diagnosed it as acute severe asthma. A
Yes, sir.
very important, understand?
Sir.
So acute severe asthma and led into he has prescribed something. Are you happy with this?
No, sir. Actually, under the age of 6 years, we do not prescribe this LABA plus Budecort combination.
Very good. So it has been prescribed and it shouldn't have been done. But yes, but he was under the impression that there is a always he thought it is acute severe asthma and he has wanted to treat this child by using controller, isn't it?
Yes, sir.
So he has used controllers, or in addition, he has also treated recurrent nebulization. History is there. So it is, the summary of this past history.
Um, Atopic march, sir,
Very
and
good.
multiple exacerbations with acute severe asthma, one episode requiring nebulizations, and furthermore, he has been put on a controller also, sir.
Okay, two things are very important here. One, it tells you that this child has got increasing severity.
Severity, yes, sir.
Yeah, that's number one. Number two, the frequency is also increased.
Yes, sir.
You see that in the last 2 months, the child has got almost every month episodes, exaggerations, isn't it?
Yes, sir.
And prior to that, he used to get once a month.
Yes, sir.
In 1 month, he has repeatedly visited and he has taken nebulizer. So that means one is there is a severity is also increasing and frequency is also increasing, and to the extent that the child has been admitted once to the hospital.
Yes,
Okay.
sir.
So if this history is there, you can think it is uncontrolled asthma. Okay.
Yes,
So uncontrolled asthma. If you say history, uncontrolled asthma, right? So with this background, now history and past history together, either there is a possibility of in this child, one is uncontrolled asthma.
controlled asthma.
Yes, with a frequent flare-ups. With
Yes, sir.
the frequent flare-ups. Okay. What is unlikely here? What is something which is not striking? What is there in this history? Yes. Okay. This you can all favor in favor of. Definitely their child has got. There is a flare-up, frequent flare-up of asthma. But what is something which is not going with asthma here?
The wet cough.
Very good. So wet cough is very, very unlikely with goes with the asthma. So, and which is in addition to that, there is a two documented pneumonias are there. Two documented pneumonia with wet cough. What else you can think?
Suppurative lung diseases, sir.
Oh, okay. What
Uh,
else can be there? Any child
immunodeficiency.
who has got this 8 months of age, 6 months of age, that means it is going on, isn't it?
Immunodeficiencies, sir. Primary
Okay.
and PIBO, sir.
Okay, we will come back to that later. So as of now, we will keep these things in mind.
Yes,
A
sir.
child who is supposed to be diagnosed as asthma has got an element of wet cough, okay, who is coming with a frequent flare-ups, isn't it? This is what your summary so far in the history and past history. We'll move on now.
Also protracted bacterial bronchitis, sir.
Very
Because
good. That is the one condition one has to keep in mind. Usually, but 1.5 years. So the PBB is very usual, common between 2 to 6 years of age.
yes, sir.
Okay, but even then it can appear after 6 months also. Okay, but what is important here is the wet cough should persist for 4 weeks.
Yes, sir.
Okay, so even there, here it is subsided. These two episodes, it is subsided after 5 days of antibiotic. Okay, so unlikely it qualifies for the features of PBB.
Yes, sir.
Okay, so now we have got so many things in mind. Let's move on.
This is a graph depicting the current illness and the past illness up till now. So, at the age of 2 months, he was diagnosed with atopic dermatitis and prescribed emollients. These episodes of cough and cold, with or without fever, have started at the age of 6 months of age, wherein he had
Mhm.
two admissions, one at 6 months and 8 months, requiring IV antibiotic and nebulizations. After that, he has had frequent nebulization use almost every 2 weeks to 1 month period.
Mhm.
And respiratory distress was there in two episodes, that is at 6 months and 8 months, which subsided during the hospital stay.
Mhm.
Nebulizations, if we notice, it has increased in frequency as the time has progressed. So it has become more frequent and more, he has been requiring the nebulizations. and IV antibiotics he has received on 2 episodes.
Okay.
MDI Furacort was started in the last one at 1 year 5 months of age, and at 18 months of age he has been admitted with us at SSIMS and RC.
Okay. So if it is a true, definitely the child is getting. If you take the backup history and all together, if you see that, how can you say what is the level of asthma control in this child?
It's very poorly controlled, sir,
Why?
because there are multiple flare-ups, and
Very
also the
good.
treatment as per
Mm.
the age group is not as per the guidelines, sir.
Under 5 years. Under five
Yes,
years.
yes, yes, sir.
Yeah, under five you should take, na. But usually under five is considered between 2 years to 6 years, not 1.5 year. This child is 1.5 year,
Yes,
isn't it? So it is very poorly. So you can label this as uncontrolled. Okay,
yes, sir.
uncontrolled. So babies every week it is getting, and most of the days of the week, isn't it?
Yes,
Most
sir.
of the days of the week. So you should ask little more history. Only what was the nebulization given? That is very important.
Yes,
So how oftenly, what type of nebulization was it being given? Nebulization means with the nebulizer machine they used to give.
yes, sir.
Anytime has it been advised, inhalers that you should ask, and what all been given? Was it only given, the relievers, or anytime controllers has been given? You mentioned the controller in the last visit, isn't it?
Yes, sir.
Prior to that, no controllers were given?
Prior to that, it has predominantly been Astelin nebulization, sir. On
Okay.
OPD visits or in at home also, they have been having Astelin nebulizations. Only after
Okay.
the last acute severe asthma, they were given MDI for a cot, sir.
Okay. So that is not advisable, isn't it? Okay. Right. We'll move on.
Birth history was normal, antenatal
Mhm.
and natal. Term baby 3 kgs via cesarean because of previous cesarean, and the baby cried immediately after birth. Postnatal also was normal with direct breastfeeding initiated within half an hour. There was no respiratory distress episodes or NICU admissions or oxygen requirement, and the baby passed urine and meconium within 24 hours of life. Developmental history is all between.
Any other history you are interested in the birth history? You have
Delayed
a 1.5 year old child who is coming with a recurrent respiratory problems. What you interested with such recurrent respiratory problems? Any child comes in this age. What else you are interested in the birth history, postnatal history?
the whether there was any NICU admission for respiratory distress, sir, and also the
Very good.
passage of meconium.
Very good. Very good. So these two unexplained respiratory distress, or a neonate has been admitted for pneumonia distress.
Sir.
Okay. That is a very significant history. And thereafter child is getting recurrent infection. What condition you think?
So we think of cystic fibrosis or primary ciliary dyskinesia, sir.
Yes, very good. So you can think of PCD. Okay. So unexplained respiratory distress during neonatal period, and thereafter child is getting recurrent cynorespiratory infections and otitis media. So those are the history. Usually you will have to ask whenever you get a recurrent respiratory infection. Okay. That's a very important history in this case. And you had 2 episodes of pneumonia. So other surface like, skin infections, ear infection should have been asked in this case. Okay. Right.
Developmental history is age appropriate. Diet is
Mhm.
also adequate in calories and proteins, and he is still continuing on breastfeeding. Immunization history is partially immunized. He has last been vaccinated at 3 months of age. Due to these frequent admissions, they have not gone for the immunization according to the mother, and BCG scar is present.
Okay.
Family history, it's a third degree consanguineous marriage and he is a third born. There are two elder siblings. There is no
Mhm.
history of pulmonary tuberculosis or asthma in the family, no history of sibling deaths or infant deaths or abortions. However, there is a significant history of allergic rhinitis in the mother and in the first sibling.
Okay, I have two questions here. One, are you still looking for tuberculosis in this child?
No, sir. Actually, we wouldn't consider it because he's thriving well and
Very good.
there is no
Next.
contact in the family.
Yes,
There is no evening rise of temperature
need not be.
or a continued course. So there is a return to
Yes,
the
that's very
baseline.
important. See, here you have a intermittent, okay? So there it is a remittent. The disease, unless you intervene, it will keep on progressing.
Progressing. Yes.
Yes, okay? And you will have a classical constitutional symptoms.
Yes,
So
sir.
classical constitutional symptoms are not there. And every episode what child is getting is very short duration.
Yes,
And
sir.
in between the child is fine. And you also told there is no growth faltering in this child. So growth is not faltered. So unlikely tuberculosis, isn't it?
Yes,
But
sir.
what is significant history here?
There is a atopy in the family, sir. The mother, the
Yes,
first
very
sibling
good.
also had.
So what is the percentage of atopy if the parents have got, which will be invariably occurs in the baby in sibling?
Almost 40%, as high
Okay,
as
so they say
40%.
one parent, 25%. If the both the parents are there, 50% more than the general population. Okay, right. We'll move on.
Socioeconomic and environmental history
Hmm.
belong to upper middle class, a modified Kuppuswamy classification. And there are five family members living at home. There are two living rooms, one kitchen and toilet and attached bathroom. It's a pakka house. There is no overcrowding. There are no pets at home. However, there is exposure to mold at home in the form of damaged damp furniture and walls in the kitchen. There is no exposure to biomass fuel or tobacco smoke or other irritants.
Okay.
Summary: a 1.5-year-old toddler boy who is a third born to a third degree consanguineously married couple, partially immunized, with significant past history of atopic dermatitis and multiple hospital admissions, with frequent nebulization use, which is responsive also, and now on MDI formoterol plus Budecort since a month, with a family history of allergic rhinitis in the mother and elder sibling, has now presented to us with complaints of wet cough, running nose for a week, and fever for 5 days. With
Okay.
this,
So what is yes, this is the history. So what is your thinking? Are you going to tell it in the next slide?
yes, sir. So coming to
Okay.
the differential diagnosis,
Mhm.
we should think of suppurative lung diseases, that is primary ciliary dyskinesia or cystic fibrosis, and protracted bacterial bronchitis. Second, I would like to keep it as a difficult to treat asthma, sir. Third, as immunodeficiencies, and fourth, as an environment triggered airway diseases.
Oh, just tell me points in favor and against.
So, for suppurative lung diseases, there is a chronic nature and a recurrence early in life, recurrent wet cough episodes, recurrent hospitalizations with the treatment to IV antibiotics with a good response, sir. Multiple upper respiratory and lower respiratory tract episodes, and also partial immunization history, which can predispose for recurrent infections.
Hmm.
The points against is a normal growth, which may always not be there. There is no significant neonatal history. There is also a coexisting atopy and a wheeze responding to bronchodilators, which is more in favor of an asthma. And also, there are no other systemic features for these suppurative lung diseases, sir.
Okay, two things are very important here, especially if you are considering protracted bacterial bronchitis,
The
growth will be
duration.
normal. Okay, invariably the child will be normal.
Yes, sir.
So it will not come in the way of development and growth of the child. So that we should keep in mind. Second thing is if you want to label any child as asthma, under 5 years and all the more less than 2 years, you should think twice because invariably in this age there will be lot many conditions which mimic like asthma and lot many conditions will have a comorbidities. So you should know all those conditions and you should rule out. So very important history you need to ask to rule out the other conditions, especially under the age of 2 years. So those 2 points you should keep in mind. Yes, otherwise the points you have taken is fine, suppurative lung diseases. So What about other conditions?
So immunodeficiencies, that is, there has been recurrent severe infections requiring a hospital stay, sir, and also fever with wet cough episodes. However, there has been no other system involvement, that there is no diarrhea or recurrent mucocutaneous candidiasis, no history suggestive of opportunistic pathogens. Pneumonia is responding well to treatment as per the history. BCG scar is present, so that means that there is a immunity mediated response, and there is no suggestive family history, sir, in the form of
Okay.
sibling deaths.
See, in immunodeficiency, still it can happen. I will tell you, younger the age, you can have humoral mediated immunodeficiency.
Yes.
So if at all immunodeficiency presents early in life, all the more usually less than 3 years, usually it will be associated with humoral immunodeficiency or combined variable immunodeficiency. What points we need to remember here is in this age, they will not have failure to thrive. Okay.
Yep.
So this humoral mediated and combined variable invariably they will not have. And younger the age, these are the two immunodeficiencies which are common. If you are thinking of cell mediated or T cell mediated, they will be older children and inevitably will have a failure to thrive. That we should remember. Okay. And as you said, their points are not in favor because no skin lesions, understand, no other systems involved, all those things are there in this child. Okay, next. What
So,
other differential diagnosis?
uncontrolled asthma, which
Mm-hmm.
we have to keep, sir, because there's a history of acute severe asthma which is documented. There is a strong
Mm-hmm.
atopic background, multiple V's which is responsive to the bronchodilators.
Mm-hmm.
Also, some has been added on a controller, sir, for a month. There is an environmental exposure in the form of molds and a pattern of symptoms, early morning symptoms, uh, which is more in favor. The points against are significant infective component was there in two of the episodes, a 6 to 8 months, which is doubtful, but he has been given IV antibiotic and wet cough. So wet cough strong points against the asthma, and also according to the history, there was a good response to antibiotics at 6 to 8 months.
Okay, so I have my observation here. Don't use the word difficult to treat asthma.
Yes, sir.
Okay, so difficult to treat asthma is an entity wherein you have three types. One is called uncontrolled asthma, wherein you are using your stiff doses of controller therapy. Okay. And in spite of that, your symptoms are not controlled. Okay. That is called uncontrolled asthma. That is an entity comes under difficult to treat asthma. Second thing is if you have to see severe asthma. What is severe asthma? Wherein you have reached your high doses of controller therapy in spite of high dose control therapy with all possible measures. So compliance, technique, delivery, device, everything has been looked into. But there, the moment you want to come down, the child will go for severity. So that is why you should be careful in using difficult to treat asthma. I would say you can use uncontrolled asthma
Uncontrolled
because
asthma.
all factors can be there. Here, there may be improper dosage, device may not be correct, drug may not be titrated well, and compliance of the patient. All 4D, they can be involved. Understand? So you use that word because you have not looked into them.
Yes, sir.
Okay, that's why you are not supposed to use difficult to treat asthma here. You can use the word uncontrolled asthma. Okay, that is the
Yes,
one
sir.
word you can use. So, but very important thing here is there an entity where you can have a wet cough, but still asthma features will be there in the child?
In the acute exacerbations, we can have a wet cough, sir, especially if there is a uh, infection triggered exacerbation. We can have a
Mhm.
wet cough, sir.
What infection? You mean to say pneumonia triggers asthma?
Um, in an uncontrolled asthma, sir, ABPA can also have a wet
No, no,
cough.
you answer to this question first. So, do you think that pneumonia exaggerates or precipitate severity of asthma?
Yes, sir.
Rarely. So no bacterial pneumonia and only mycoplasma. Okay. No other pneumonia, bacterial pneumonia will exaggerate asthma. So that we should remember. Invariably, it is the viral episodes which will usually exaggerate and child develops a flare up. Okay.
Yes.
So that is the reason you should always think that. But conditions with a wet cough, where else you can have a child responds to nebulization, but still they will have a wet cough. Those conditions I am asking you.
Mm.
Because that is what is coming in your way of asthma, isn't it now? So now you cannot say it is ongoing wet cough. No, there is no constant history, but child is used to recover. But child is responding well to your asthma treatment also. So, so what are the entities wherein we should think of asthma like features and it's responding and with wet cough. So those conditions we should keep in mind. Anything strike to you? You said
Aller-
something?
Allergic bronchopulmonary aspergillosis in
Yes,
uncontrolled
very good.
asthma.
Very good. Very good. So we're in uncontrolled asthma features, but cough will be wet
Wet
and
type.
it will be an wet cough in between. Intermittent wet cough can be there. So that is one of the classical cases wherein you can get this. Number two,
Mm.
they do have asthma features. They do respond, but still they will have a wet cough.
Episodic viral wheezes. So,
No, episodic viral wheezers in between child will not have asthma symptoms.
so
And it is very short duration. And unless there is a viral infection, you will not get. This child had only 2 episodes of fever. Rest all the time it was getting only trigger
wet
induced.
cough and cold. Yes, sir.
Yeah. Then any other conditions?
In PCD, sir.
No, PCD, why the child will have asthma-like features? It will not have asthma-like features. So some of the cases with bronchiectasis, understand, they do have an obstructive component and they also respond, but they will have a wet cough.
Yes.
Okay. And another important thing is you have, yes, you heard about Loeffler's pneumonia.
Yes, sir.
Yeah, they do respond like this and they present like this. They respond for your bronchodilator therapy and they, but it will be very short duration. Okay. Any other conditions?
Hypersensitivity
Very
pneumonitis.
good. As per sensitivity pneumonitis, they do respond and they improve. Yes, next, any other?
I'm not sure of any other, sir.
Okay. Idiopathic eosinophilic lung diseases.
Yes.
Okay. So they behave like a asthma patients and they will have all characteristic feature of asthma, but they will also have a wet cough. Okay. They will have a wet cough. Drug induced can also be there.
Yes,
Okay.
sir.
So drug induced. So what is ultimately is you should remember this hypersensitivity pneumonitis and eosinophilic lung disease. There are group of eosinophilic lung disease. So many of them behave like asthma with a wet cough. That is another important. And some of these cystic fibrosis cases, they do respond. They behave like a asthma patients and they will have bronchiectasis and they will have a wet cough also and they do present like this.
Yes.
Okay. So these are few of the other differential diagnosis. Any other things you have considered?
I've put environment triggered avid diseases, sir, like
Very
hypersensitivity,
good. Yes.
hypersensitivity,
Yes.
because there is an
Yes.
exposure also, sir.
Yes. Any other things?
Mm.
See, environment is very important history. Okay. So any patient with the especially, the usually you heard about, but it is not common in this age, but it can happen. Okay.
Yes, sir.
So if a child exposed to pigeons, okay, pigeon excreta, they will have this type of presentation.
Yes, sir.
Okay, right.
Coming to the examination, the child is sitting comfortably on the mother's lap with the IV cannula present on the right hand. He was hemodynamically stable, afebrile, no respiratory distress, and he was well perfused and saturation was normal at room air. Head to toe examination was entirely normal except for the watery nasal discharge, and hyperpigmented thickened flexural skin was also noted, suggestive of atopic dermatitis. There was
Mhm.
no clubbing or cyanosis or pedal edema.
Okay, very good. What else you want to emphasize? Because you have a couple of differential diagnoses in mind, and when you go to the patient while examining, you should keep all those differential diagnoses and points in favor you have to see. If you
Yes,
go with that note in mind, then you will pick up lot many signs in the child. So I appreciate really one you have looked for any allergic markers. That's very thing. But what is important here is child is just 1.5 year.
yes,
So
sir.
unlikely unless they have, atopic dermatitis or eczema. And second important thing is you have looked for a clubbing.
Yes,
Okay.
sir.
So that is also very important thing. Any other things you want to see in this child? Keeping those differential diagnoses in mind.
Nasal polyps we have to look for, sir.
So very, very early.
Pale nasal mucosa, ear
Uh-huh.
discharge,
Yes.
other skin
Agreed.
involvement,
Agreed. You have seen, you have examined the nose for the allergic manifestations. Fine. What else?
other skin infections, sir.
Yes. What other skin infection you have in your mind?
Uh, in the form of um, pyoderma,
Mm-hmm. Yes.
deep-seated abscesses.
So you are thinking of immunodeficiency, isn't it? So for that, what are the points in favor? You should look for it. Any scar, pyodermal scars. Yes, agreed. Any fissures, any abscesses. Okay, fine. Apart from that,
Candidiasis.
yes.
Yes.
What else? You said, na, the one of the last differential diagnosis you were keeping in mind is
Hypersensitivity.
yes. What you will see in the skin?
Hyperpigmented.
No, skin lesions.
Yes, sir.
So skin lesions are very important. Understand? And joint swellings. Okay. So joint tenderness, swollen joints. Understand? Especially small joints. You should look for them because they are the one which will have usually associated immune mediated conditions. Okay. And
Yes.
especially vasculitis features you should see, and that is the last in order. But on examination you should keep in mind and look for them. Keep in mind and look for them.
Yes.
Okay, next. And ENT examination is very important, huh? Look for the any, ENT, especially the ear involvement. Okay.
Yes. No ear discharge or no
Hmm.
inflammation or any signs of infection of the ear cavities.
Okay, very good.
Coming to the anthropometry, as we can see, all of the parameters are normal. And
Mhm.
on plotting in the growth chart also, he has been following the same centiles. There has been no growth faltering or failure to gain weight. His HC and length are also normal, and his weight for length is also normal.
Okay, so what is important here is the disease which usually affect the growth are not there, unlikely, isn't it?
So,
Right, next.
coming to the systemic examination, respiratory system, the upper respiratory tract, external nares were normal. There is bilateral inferior turbinate hypertrophy with pale mucosa, and there were no polyps. Good oral cavity hygiene, lips, tongue, teeth, and gums were normal. The posterior pharyngeal wall and the palate were normal. There was a grade 2 tonsillar enlargement, no congestion, and the ears were also normal, sir.
Hmm, okay.
Inspection, Type, thoracoabdominal type of breathing, no retractions or labor breathing, normal depth of respiration. The shape of the chest was symmetrical and normal. Chest wall movements were also symmetrical. Apical impulse was normal. Trachea appeared central. No deformities of the chest wall, no scars, veins, or sinuses, and the spine was also normal.
Hmm.
Palpation, there is no local rise of temperature or tenderness. Apex beat was also confirmed to be in the same place and normal. Trachea was central, bilateral chest movements were equal, and tactile vocal phragmitis were equal bilaterally. However, because this is a very small child, it is a little difficult to comment on the trachea being central and also the tactile vocal phragmitis being equal bilaterally.
Mhm.
On percussion, there was a resonant note in all the areas except in the areas of the cardiac dullness and the liver dullness. And on auscultation, there was a sound known as squawking, which was heard in the right mammary, axillary, infraaxillary, and the infrascapular areas, as well as the left mammary, axillary, infrascapular, and the interscapular areas.
Can you just brief me what is quacking?
A squawking is a sound which is heard in a combination of a crackles as well as a ronchi, sir. And it is mostly seen when the interstitium is involved or when the smaller bronchioles are involved, sir.
When it is not able to differentiate,
Differentiate. Yes.
okay, you are not in a position to differentiate crackles, you are not able to differentiate rhonchi, but definitely you are hearing something hard, okay?
Yes, sir.
So that is what is quacking. So this quacking sound, okay, so whenever you get this, what strikes through your mind?
It is characteristically heard in interstitial lung diseases, sir.
Mhm.
Squawking as well.
So what other
Bronchiectasis.
important thing you have noticed here is
In bronchiectasis also.
no, no, that is coarse leathery crepitations.
Sir.
Very important thing here. You have seen, look at this. This is bilateral,
Yes, sir.
extensive multilobar involvement. So this disease is not localized, isn't
Sir.
it? It is bilateral, extensive, isn't it?
Sir.
Okay. Hmm.
Other systemic examination was essentially normal and there was no involvement.
Mm-hmm.
So, with this, again, we will revisit our differential diagnosis. And there are several points against suppurative lung diseases after the examination, considering the normal growth as well as the characteristic sound of squawking, which is not usually seen in suppurative lung diseases.
Hmm.
And uncontrolled asthma. Also, there are nasal allergy findings as well as the recurrent cough episodes with bronchodilator responsiveness. And the squawking episodes could be a complication of ABPA, sir, in this child.
Mm-hmm. Only one condition. See, you cannot make out squawking in all whole together ABPA. But squawking will tell you that there is a extensive involvement and which is involving the parenchyma. Okay? So it is long standing. So you will have to think this quacking is a nature of interstitial lung disease.
Yes, sir.
Okay? So that is what makes difference. See, all this time we were thinking that this child has got probably those are the conditions you were, isn't it?
Yes, sir.
So you were thinking possibility of suppurative lung disease, immunodeficiency disorders, and asthma,
Yes, sir.
isn't it? But in these three conditions, you don't get squawking auscultatory findings. Okay? You don't get squawking auscultatory. So if you heard that sound on auscultation, you will should become alert. What is this which is not you were thinking all this, isn't it?
Yes, sir.
Okay, so that is what is very important finding in this child. And all the more, just 1.5-year-old child coming with such a, as if you are auscultating on hard object. Okay, that is what is the nature.
Yes,
Right.
sir. Coming to the investigations of this child,
Hmm.
So these are the serial investigations which have been there since the age of like 1 year, 5 months and coming to now. So what is characteristically seen, the abnormals are that there is a raised total count on some of the episodes, and there has been a neutrophilic predominance in the previous episode and an elevated CRP also. But what else we can see from all of these differentials is in most of the situations the eosinophil count has been very high. The differential, that is in the first 11th of December it is 9%, then 4%, 6%, and when we calculate it manually it is all coming around 990, 1100, 768, 834, 528 and 1158. So because of this we have sent absolute eosinophil count as well as total IgE in our center, and that has come as 2310 and an AAC of 9650, which is very, very elevated.
What do you mean by normal level when you call it is a eosinophilia?
So for this age group, the total IgE more than 500 as well as an AEC more than 500 is considered to be eosinophilia, sir.
So significant eosinophilia. But if it is usually the current recommendation, it all depends upon your local strength. So 150 in the blood, okay, eosinophil count more than 150 cells is, isn't it? So 500 cells is significant, okay? It's very significant. You should concentrate. And IgE level more than 500. But look at this. What is the amount?
2310, sir.
Okay, so if you, there is two way of calculating absolute eosinophil count. If you just take a percentage, you go back to one slide, they take out this red, see there, yeah, you project that another, one more click. Yeah, see there, it is 990, 1100. What has happened here is, even in our center also, okay, usually they calculate the percentage of the eosinophils and to the total leukocyte count, and they derive this figure, that is 1372. When you ask them to count the eosinophils on counting chamber, then you get the real counting. So whenever it is more than, whenever you get more than, 500 eosinophil count, you should be careful and make sure that, and all the more, any child who has got asthma and eosinophil count is very high, it will also make the, you can make the phenotyping of the asthma also, and you will come to know what is the absolute eosinophil count. So for our surprise, what is there in our mind, what is happening with this child, and we didn't just take it as, otherwise most of us will take it as asthma and eosinophilia, isn't it? So you usually carried away saying that is the Th2 type of asthma, high Th2 type of asthma with eosinophil inflammation. So we will treat and they respond very well. They do respond very well for your controller therapy. But what is important here, why asthma child should get that squawking child nature? Okay, that is the most important thing which made us to think further in this child. Okay, so then we sent it. So now this child has got very high IgE level and very high eosinophil count. It is in thousands. So whenever you get eosinophils more than 1000, you should always think of, remember, we should think of eosinophil lung disease. Okay, so that is what is very important in this. You see the summary. Yes, in between, the child has got, probably an infection, bacterial infection. There you have a, usually the neutrophilic predominant leukocytosis, and that's why the ESR is also raised. Okay, next.
So then this was a chest X-ray done in our center. So this is the chest X-ray of the child, and we can see that there is a bilateral extensive multilobar involvement, and this is predominantly from the center to the periphery, and there are also multiple finger-like projections which are coming from the center to the periphery, sir.
No, I will show you very important finding in this X-ray. You see the retrocardiac, okay, behind the card. Can you see my cursor? No. Okay, this you can see here behind the card. That is called as fingers in the glove. Okay.
Yes, sir.
So fingers in the glove you can make out here a classical. Another thing is toothpaste appearance. So there are few couple of findings which are there. So you can see here, it's very important. Yeah, below the cardia, you can see that there is a shadow.
Yes,
Yeah,
sir.
yes, 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 very good. So that is what is. So say it is a tubular or toothpaste or finger in the glove. These
Yes,
features are a very, very important things. That will tell you that there is a lot of secretion in bronchial,
yes,
endobronchial, lot of secretion is there. Okay. So that may be due to even mucus plugging also. Okay.
yes.
Next.
These are the serial X-rays, and in these
Hmm.
X-rays also we can see that retrocardiac
Yes,
fingering.
very good.
In the one in October also it is there, and this is the last one is in our center.
Yeah. See, you can see that there are some types of usually perihilar, these projections are there. But in this child, there is very prominent retrocardiac.
Yes,
Okay. In the latest X-ray, it is on this last month. So this is very important. And you can see here, these are the finger-like projections. Okay. And they are also called as tram track appearance, and you make out those obviously in CT scan. So what next investigation you have done?
we did a bronchoscopy for this child to
Uh-huh.
see the airway as well as to collect the bronchoalveolar lavage sample.
Hmm.
And in this, the airway was normal,
Hmm.
and
What is
the
the why?
ball.
Why did you do the bronchoscopy? In asthma child, you do bronchoscopy?
No, so because of the atypical and uncontrolled as well as his hypereosinophilia findings, to collect the bronchoalveolar lavage, we have done the bronchoscopy, sir.
Yes, you have to see whether this child has got any eosinophilic lung disease.
Yes, sir.
That is a very important thing. You want to see in the bronchoalveolar lavage what is the eosinophil count. So, what in more amount of eosinophil count will tell you that possibility of eosinophilic lung disease?
More than 25% in the bile eosinophils is said to be a significant bile eosinophilia, sir.
So anything more than 10% will guide you that you have to think. So you need another further investigation. So if the ball eosinophil count, otherwise what is eosinophil count in the ball?
It should be less than 1%, sir.
Zero. Usually
Yes.
less than 1%. Okay. So that is not. So that is the reason you have collected ball. Number two, what else you will do with this ball? What are there in your mind? What are the differential diagnoses?
The infective etiology like protracted bacterial bronchitis, to look for
Yes.
neutrophils and the lymphocytes, sir.
Mm-hmm.
To look for any, the culture, sir, whether it is growing any organism.
Yeah, very good. So you should look for organism. If it is a polymicrobial or if you grow at Pseudomonas, then it will tell you something, isn't it? Okay.
Pseudomonas would point to cystic fibrosis, sir.
Yes, very good. Next.
And then this were the investigations which came in the hospital. It is showing a
Hmm.
10% lymphocytes and a 60% neutrophils, which is suggestive of an infective etiology. And
Hmm.
also few gram-negative bacilli, occasional gram-positive cocci, no
Hmm.
acid-fast bacilli were seen.
Hmm. Next.
This was the slides that we got because in our hospital they did not report on any eosinophils. But because we had a high index of suspicion, we sent this to an outside lab. And you can see in this smear that there are multiple eosinophils in each high power field. So then we
Mhm.
found out that there was eosinophils of 60% and the impression was an inflammatory smear with eosinophilia.
Hmm. Okay. So what is the percentage? 60%, isn't it? Very significant eosinophil count in this child, right?
Yes, sir.
Okay. Next.
Furthermore, the culture at the PCR panel confirmed Streptococcus pneumoniae and H. influenzae, and the
Hmm.
culture showed a moderate growth of Streptococcus pneumoniae, which was
Okay.
sensitive to linezolid. So he was given 2 weeks of linezolid therapy also after this report.
Hmm. Okay.
This was a CT of the child.
Mhm. So this is a lung window. You can stop in between. You can show them classical features. Yeah.
Yes. In this, we can see that the involvement at the periphery is almost till the edge.
Mhm.
So anything within like 3 millimeters is said to be suggestive of bronchiectasis. Also,
Mhm.
there are multiple areas of um, This is like tram track opacities.
Very good.
Certain signet ring is also present, sir.
Yes, you can see that there is a bronchiectatic changes here. Okay.
Also here there is
Right.
an area of consolidation in the lower lobe of the left side.
Mm-hmm. So there is a one more important, just hold on. You see here, this is called, okay. So
Yes,
this is called, just see there on the top. And very important here is this CT is showing there is a pseudoglandular appearance, okay, from the mediastinum. Okay, next. Yeah,
this also we can see ground glassing and mosaic attenuation as well as a consolidative area in the left lower lobe.
yeah, okay. So there are bronchiectatic changes. There
Yes,
are classical features of, you know, I told you, there is a tram track
like
appearance,
appearance.
isn't it? And toothpaste appearance. Then you will see that if you classically just zoom this, there are even bronchiocele. That means dilatation of the bronchus. That is because of lot of mucus plugging. You can see here, isn't it, in the periphery? So you
Yes,
don't see otherwise. You can see on the left side also.
yes.
So there are dilatations. Okay. So all classical features are there. Next.
So based on all of this, we kept the diagnosis of hypereosinophilic lung diseases in mind, and because of the background history of uncontrolled asthma and all of these features, we did the Aspergillus fumigatus specific IgE. So that
Oh,
came to be 0.22, which is elevated and double the normal.
yes, very good. Next, what you will do if that is there
And also we did the skin prick test, which was positive for Aspergillus niger and fumigatus.
with the good negative and positive control.
Positive control. Yes, sir.
Okay.
Good negative control is said to be when it is at least less than 3 mm. Positive control should be 3 mm more than that, and a positive test should be at least more than or equal to the negative control, sir. So this
Okay.
test is come positive for Aspergillus niger and fumigatus.
So now you have a specific IgE is also positive. Skin
Yes,
prick test is also positive. Okay. There is X-ray evidence and
yes,
uncontrolled asthma.
yes, sir.
Okay. So can you correlate all these things?
So because of all of these features, uncontrolled asthma, hypereosinophilic lung disease, positive IgE and skin prick test also positive, we have thought of allergic bronchopulmonary aspergillosis. And this table is taken from American Academy of Pediatrics textbook 2024 edition, that is the second one. And in these 9 points, the first 5 have to be present. That is an underlying diagnosis of asthma, proximal bronchiectasis, positive skin test to Aspergillus fumigatus, elevated total IgE, elevated IgE and or IgG to Aspergillus fumigatus, infiltrates on a chest radiograph, a positive presbyopia test to Aspergillus fumigatus, eosinophilia, and a sputum containing Aspergillus fumigatus. Of these, we have the first 6 being positive and the 8th one also being positive, sir.
Okay. So
The
it,
recent
yeah, go ahead.
The recent guidelines are the ISHAM guidelines, and this
Hmm.
is from the 2024 guidelines. So the predisposing conditions for us was asthma, an uncontrolled asthma, and the essential components are an Aspergillus fumigatus Ig more than 0.35 and a serum total Ig more than or equal to 500. So if
Hmm.
we are not able to do the specific Ig, even a skin prick test can be considered acceptable for the essential component, and we have that one also. And any two of the other components should be present. That is a positive IgG against Aspergillus fumigatus, a blood eosinophil count more than 500, thin section chest CT findings consistent with ABPA. So we have the last two.
Hmm. Any two are there, isn't it?
Yes, sir.
So,
The, yes, sir. The
yes,
last.
good. Right.
Furthermore, there is a classification based on the radiological classifications. So ours
Hmm.
is fitting into the ABPA with bronchiectasis.
Okay. So you have already bronchiectasis. I would suggest, see, you have seen that tram track appearance and no fingers in glove and toothpaste appearance. All those things are there. So I would say you should have ABPA with mucus plugging. Okay.
Yes.
So this is fitting into our diagnosis. So this is a case of ABPA with mucus plugging.
Mucus plugging.
Okay. Very good. What is the management schedule for this child?
So again, for the management, it is a stage treatment. So we have to classify into the stages. These are the 5 stages, that is acute, response, remission, treatment dependent, and advanced. So
Okay.
ours is fitting into the acute ABPA because he has been newly diagnosed, and as well as exacerbations are taken into the acute category.
Hmm.
So our final diagnosis, I would like to revise it to allergic bronchopulmonary aspergillosis, that is ABPA with mucus plugging with an underlying uncontrolled bronchial asthma.
Hmm.
For his treatment for newly diagnosed is, we have put this child on oral glucocorticoids in a stepwise approach. So we have begun him with oral glucocorticoids, and this is the dosing of this child, that is 0.5 mg per kg per day for 2 weeks, and then for alternate days, and then to taper by 5 mg every 2 weeks. So this is a prolonged treatment.
Hmm.
Apart from this, we have to also, for his asthma management, a regular inhaled corticosteroid. So we have added him on budesonide 100 mg, 1 puff BD. And whenever he has an infective exacerbation or an airway exacerbation, we have defined a plan for him to maximize the airway clearance because of the bronchiectasis changes,
Hmm.
and to also do an environmental control.
Okay.
So a note on the environmental control is, because it is the molds, the hidden leaks, fogging of glass windows is a sign. We have to ensure the proper ventilation and regular cleaning and dusting of living spaces, not to ignore the wet spots or water stains.
Yeah.
The take-home messages are: uncontrolled asthma is a red flag. Always consider ABPA when such cases present to us. ABPA mimics asthma, but it behaves in a worse manner. That is, there is recurrent wheeze, cough, and mucus plugs. Fleeting shadows are not innocent, so transient infiltrates also should raise a suspicion, and early identification prevents an irreversible sequelae. Timely intervention will reduce the risk of bronchiectasis and a chronic lung impairment.
Very good.
This is a short flowchart on the hypereosinophilic lung diseases. It is
No,
broadly classified.
yeah, I think you stop there only because it will take you to somewhere else. So that is a very important aspect. Go back to the last slide in take home messages. Okay, so environment is very important in asthma patients because asthma always triggered. It is triggered. So triggering factor should be eliminated. So if you see the steps of management of GINA, in every step, the bottom line is take away the triggers.
Yes.
Okay. So the triggers has to be taken away. So that's very important, and environment is very important. So ventilation is the most important thing. Whenever the ventilation fails, that means in a house, it should be well ventilated. That means at least 6 cycles of air should run through the house. So that's why doors and windows should be kept open. And otherwise, what happens once the humidity drops down, these molds will start growing. Okay. So that is the reason you should be very careful and tell the parents what is that trigger you have to avoid, how you have to avoid, and what care has to be taken. That is the most important thing. Okay, now you have started this child on your steroid therapy. If it fails, what is the next line?
The next line is, we would have to start on the systemic antifungal, sir. That is
Okay.
itraconazole, voriconazole, or posaconazole.
Okay.
Most commonly used are itraconazole or voriconazole, sir.
Okay. So now we have started only now
Oral.
steroids. We are
Yes.
waiting for the child for follow-up. Once the
Yes.
child, because it has been diagnosed last month, so we are planning to give 4 weeks, isn't it? 2 weeks first and tapering, isn't it? Thereafter, and
Yes,
then
sir.
we'll see. So I think Dr. Rochelle, you have done extremely well, good job, and you know, very nicely presented and very elaborative. And it was indeed a very good case discussion. I'm very happy with that, the way you have approached this case.
Thank you, sir. Thank you for moderating the session, sir.
Thank you
And I
so much.
think over to, yeah, Sinchana.
Yes, sir. Thank you so much, sir, for moderating this session. And it was very well presented by Dr. Rochelle. Many congratulations to her. And it was a very interesting case, sir, actually. And it was thoroughly worked up also, and we could come to a diagnosis. And actually, I feel, sir, isn't it an unusual presentation to have as ABP at this young age, sir? Like,
No, that is what I'm telling you. So that is
yeah,
what is made us to think and unusual things, that is the reason we are presenting here, number one.
yes,
Number two is, see, you should keep a high index of suspicion whenever the asthma
yes,
doesn't behave the way you want it. Okay?
mm,
So that was a clue for us in this chat.
yes. And sometimes even this home nebulizations can also be a source of, because we had one baby with a child who was given frequent
Yeah,
nebulizations.
see,
And
yes,
yes,
definitely. These fungal filaments can come from anywhere. Okay, so wherever there is a the humidity is low or the moisture is there, especially AC ducts, and
mm,
these real sources. And if they are not well maintained, and nebulization should not be advised. And we are not using nebulization machines for almost 1.5 decade now. So
correct,
we
yes, sir.
don't get any chance of using them because we use spacer and MDI. If a child is sick, not able to, when child has come in a sick and hurried breathing and distress and not maintaining saturation, you use the oxygen driven nebulization.
Oxygen,
Okay, so
yes,
there is nowhere, I would say the pediatrician should never, talk about these nebulizer machines year afterwards.
mm, correct, sir. Thank you so much for the excellent take home messages for all the pediatricians and practicing allergists also. So it was an excellent session. Thank you for being with us tonight on this platform. There are no questions in the chat box, and I think we can wind up
Okay,
at present. Thank
thank
you
you.
so much.
Thank you very much for the opportunity, Mama.
Thank you,
Okay,
sir. Thank you, ma'am,
thank
and
you.
thank you to Neeraj sir also, ma'am. Thank you, sir.
Yeah,
Thank you, Dr. Roshil.
yeah,
Good night.
please.
Yes,
Thank you very much in total for the national chapter.
yes, sir. It's a privilege, sir, to have this, and it was a very nice case that we could learn from. Yes,
Yeah, Rochelle, you can stop sharing.
yes,
Yeah, if there are no questions, thank you.
yes. Thank you, sir.
Thanks to the chapter.
Thank you, sir.